Which route of hysterectomy is the best route of hysterectomy? I get this question a lot, and I'm starting to get a lot here on YouTube. So let's go over that. Laparoscopic, vaginal, abdominal, maybe even robotic. Which route of hysterectomy is potentially the best for you? Again, my name is Eric Schmidt. I'm a board-certified OBGYN, minimally invasive gynecologic surgeon. Let's talk about hysterectomy in this video. If you want to go ahead and view our podcast videos on hysterectomy, I did a couple of videos with Dr. Valieva. I'll link one right here so you can maybe catch up what exactly hysterectomy is. But briefly, let's go over it. So hysterectomy is the removal of the uterus. Uterus kind of like a pear-shaped organ here. Cervix is here. Tubes each side. Ovaries each side. And so the inside the uterus there. So hysterectomy is the removal of the uterus, okay? First and foremost, it doesn't have anything to do with the removal of the fallopian tubes or the ovaries. That is a separate procedure. And so you might hear me call salpingectomy the removal of the fallopian tubes, or oophorectomy would be removal of the ovaries. Okay, but now we're just focusing mainly on the removal of the uterus, which would be hysterectomy. For the purposes of this talk, now we're going to be talking about somebody that's getting a hysterectomy for a benign reason, meaning that it's not a cancerous reason, because that can change the game completely. Now these reasons would be like bleeding, fibroids, pain. And so just keep that in mind when we're going through this talk. When we're selecting which way would be best for each patient, and during this discussion we're having with the patient, understanding their problems, understanding their history, in our mind we're kind of coming up with and molding the best option for them. And so often when we're talking with patients, we're going to be asking a lot of questions. What's your prior surgical history? Have you had a lot of C-sections? Have you had a lot of vaginal deliveries, or none at all? And so this often might play into the question of which way is the best way for you. And then we're really looking into why the patient is having the hysterectomy. Obviously, we want a really good reason to do a surgery. And so we might be asking questions or seeking out information regarding things like fibroids, things like persistent pelvic pain. Do we have a high suspicion this patient might have things like endometriosis? Those might play into which decision, which route of hysterectomy we want to go with. And sometimes certain medical comorbidities or medical problems that some patients may have actually may dictate or tell us which option may be best for them. Okay, let's talk first about an abdominal hysterectomy. This is kind of the default, kind of maybe along with vaginal, the oldest. Previously, one of the most common ways to do a hysterectomy because of the lack of technology at certain times. Because an abdominal way, you're making an incision, sometimes often like a C-section cut incision over the pubic hair, or even if they need to, potentially a vertical or up and down cut from the pubic bone, maybe up to the belly button. But luckily, this is becoming less and less common because of a number of things we'll talk about right here. Like we said, it's kind of the default, because if you can't complete a surgery vaginally, whether there's complications or the difficult nature of the case, or laparoscopically, this is the way you would complete the surgery. Do what we call it would be a conversion, or having to change from one to the other during that surgery because of any of those reasons. It's also the most maximally invasive. Like I said, I'm a minimally invasive surgeon. This would be the maximally invasive way to do the surgery, and we really try to avoid it at all costs as long as we're keeping our patients safe. There are some situations which we may need to do abdominal hysterectomy, whether it's a case where there's cancer, or the uterus is so large, or there's complications during the surgery. All those potentially might be reasons why somebody might have an abdominal hysterectomy. But again, this should be less and less common with better technology, better techniques within our profession. It's likely very obvious, but why don't we want this way? Well, number one, it causes more pain. We're doing a larger cut. We're having to open a lot of the fascia in the core, and so this causes more pain afterwards. And traditionally, patients are much slower to return to their normal activity, and that also can be on the order of potential weeks where they're just not feeling like themselves, limited activity, and so again, not the best way. And there's more scar tissue. So if by chance someone needs a future surgery, again, for any other reason, there might be more scar tissue within the abdomen and pelvis. All right, let's move on to minimally invasive hysterectomy, because this really should be the standard of care. Besides those other couple reasons why we said abdominal hysterectomy may be warranted, should be generally the first approach. And so let's talk about vaginal first. So vaginal hysterectomy, it's done through Obviously, the vagina. And it's a smaller opening, smaller working area than a lot of the other procedures where you may have more access to the surrounding tissues. So, vaginal hysterectomy does take a fair amount of skill. It's a nice, usually quicker procedure because we don't have to do a lot of setup. We might have to do with laparoscopic and robotic surgery, even abdominal surgery. So, vaginal often can be the quickest patient to sleep, patient to waking up. However, that's what the studies say. If someone is very proficient in laparoscopic abdominal, they generally have systems around them that make it just about as quick. So we'll keep that in mind. Again, this takes less potential technology resources, making it potentially, maybe even, if we're thinking about healthcare, economics, and cost, you'll see that there would be a potential smaller cost. Generally, this wouldn't be to the patient, but there can be a smaller cost to the hospital system. And so vaginal hysterectomy can also have its limitation, meaning it might not be the best for everyone. And so some of those cases might be if someone has a significantly enlarged uterus, their surgeon may not feel the most comfortable doing a vaginal hysterectomy. This would be from things like fibroids, but vaginal approach might not be the best to them because if someone has big fibroids up here on their uterus, going through this tiny incision and working your way up to do the surgery can be difficult. Really getting around those more difficult surgeries. Also, limitations would be you just don't have as good of a visualization of the pelvis as you would if you're looking down laparoscopically. To look out for things like scar tissue or things like endometriosis. If someone often is coming to me because they've had pain or want to be investigated for endometriosis or something like that. Also, it'd be harder to do that during their their vaginal hysterectomy. Also, if someone wants a supracervical hysterectomy, meaning they want to keep their cervix, and so we'll I think talk more about this. We talk about it a little bit in our videos, but sometimes if someone really feels like they want to keep their cervix to keep as much anatomy as possible, and there are certain situations where this may be good, especially if someone has a lot of sensation, positive sensation from their cervix from things like intercourse, they might want to keep their cervix. And so you can't do that vaginally. Okay, that can really only be accomplished laparoscopically for the minimally invasive ways or abdominally that the cervix can be kept. But you can't start your procedure in the vagina and get up and do the rest of hysterectomy and save the cervix, unfortunately. Okay, let's talk about laparoscopic hysterectomy. This has become more and more popular because technology and teaching for this is becoming more and more precise and better. And so laparoscopic is definitely getting more common. Now, this would be tiny incisions, usually less than a centimeter in size across the belly. Usually for a normal case, you might have one in your belly button, one to each side, potentially at one or two others. Again, usually depends on surgeon preference or complexity of the case. The nice thing about laparoscopic surgery is one, it's minimally invasive, so quick recovery, minimal to less pain when comparing to abdominal hysterectomy for sure. And what's going to separate laparoscopic from vaginal is you just get a much better visualization of the pelvis because you're looking from a different angle. And so if someone has potential other disease, ovarian cyst that needs to be taken off, endometriosis that needs to be dealt with, often laparoscopic is going to be a better way to address that. We didn't talk about it before, but if we're including removing the fallopian tubes and removing the ovaries, it might be slightly easier to do that laparoscopically, but someone can definitely do that vaginally. So that isn't always a drawback to vaginal surgery. Now, minor details about this. Again, I mentioned that it might take slightly longer because of the setup to do a laparoscopic case. However, again, with someone that's really proficient with doing gynecologic surgery, this is minimal. When it comes to complication rates, they're very similar to abdominal and actually vaginal too. Let's talk about robotics because robotics is actually just a form of laparoscopic. People think often it might be a different approach or way of doing the surgery. No, it's actually a laparoscopic way. It may give you benefits such as finer dissection if someone has a more complicated case, potentially more efficient. And so robotics is just a part of laparoscopic. It's really not any different. It's your surgeon's preference. So let's talk through a couple cases which you may commonly see. Okay, if someone has a slightly enlarged uterus, let's say 12 centimeters in size, that means here to here, but there's no suspected other abnormalities. And so which way is the best for this patient? Now, your surgeon might be taking into account other things like have they had vaginal deliveries before? That makes it easier and the vagina opening a little bit more accessible. And so you definitely likely still have the option of vaginal versus laparoscopic. Now, if somebody has a history of 5 C-sections, meaning they've had a cut through this area of the abdominal wall and uterus and cervix, they're going to have a lot of scar tissue. And so when you're coming up vaginally, that can be potentially a little more difficult. Requires extra skill, extra attention when you're doing that vaginally. Whereas, again, more visualization, potentially better dissection laparoscopically. And so often if someone has a more complicated surgical history like this, they might choose to do a laparoscopic approach. Let's talk about if someone has had a large fibroid uterus. Again, big fibroids there. Each surgeon has their own comfortability when it comes, if that's a word, when it comes to things like large fibroids and uterus. And so not every gynecologic surgeon may feel comfortable with large fibroids and doing it with a minimally invasive approach. If a fibroids are starting to grow bigger, whether that's, lime, lemon, grapefruit sized, I try to encourage patients that if they are being consulted and abdominal hysterectomy is being recommended for large fibroids, you may want to get a second opinion. Make sure you're seeing somebody that does a lot of gynecologic surgery, because often there can be somebody that does it minimally invasively when someone might do it abdominally, just on comfort level, experience level, and how much exposure do they have to these type of complex cases. So even with a large fibroid uterus, and we're talking grapefruit or larger size, it often can be done laparoscopically still, maybe even vaginally with an expert vaginal surgeon. And so if you're being recommended abdominal hysterectomy and it's not for anything like cancer, you may just want to talk through some of these points with your doctor and have a better understanding why we're doing a larger, more invasive approach, and potentially getting a second opinion. Again, there's nothing wrong with that. Finally, let's answer the question, which option is the best for you? And often, again, your doctor is going through a lot of these different questions in their mind, figuring out whether this is the safest option for you. And so often, the best route is what your doctor is going to recommend, because they're taking into account a lot of these factors. But as long as you're getting a minimally invasive approach, that generally is the main key. So whether it's vaginal or whether it's laparoscopic, there's not a big difference there. Despite having to make some abdominal incisions, the pain afterwards is not too different. So the recovery is quicker. You're back to your normal activity quicker. Hopefully less pain, less scarring, less interruption to your life, as long as it's a minimally invasive approach. But if someone is recommending abdominal, that's more maximally invasive. You might want to ask more questions about this. Why are we doing it this way? Potentially getting a second opinion. So that's the main point of this talk. Minimally invasive is the new standard. And so hopefully your doctor is recommending one of those ways. Again, it doesn't matter as much whether it's vaginal or laparoscopic. They're computing a lot of different reasons why which route is best for you. All right, everybody, that concludes our talk. Thanks for listening. Everybody have a great holiday. We'll talk to you soon.